Welcome back to the deep dive. We are wading into some pretty deep waters today. If you're listening to this, chances are you've got a massive exam on the horizon, maybe your MD finals, maybe a high-stakes board certification, and you are staring down the barrel of one of the most complex, physiology-heavy topics in the entire syllabus.
It really is the final boss of anesthesia exams. We are talking about thoracic spine surgery, scoliosis, and the anesthetic management of patients with kyphoscoliosis.
And this isn't just a check-the-box topic, is it? This is the 20-mark long answer question. This is the case that shows up in the Viva, and it separates the students who memorized a few drug doses from the students who actually understand respiratory mechanics and cardiovascular physiology.
Exactly. If you get this case in an exam, the examiner as well, they're rubbing their hands together because it tests everything. It's a restrictive lung disease case. It's a pulmonary hypertension case. It's a difficult airway case. It's a massive hemorrhage case. And it involves prone positioning, which is, a physiological nightmare in itself.
So, consider us your study buddies for this. We have combed through Miller, Morgan, the standard case discussion books, and the high-yield question banks. Our mission is to take that mountain of text and distill it into the perfect structure for your exam answer. We're going to build this logically, section by section, just like you would write it on the paper.
Right. Let's get straight to it. Part A, the basics.
Okay. You are in the exam hall. You turn the page. Discuss the anesthetic management of kyphoscoliosis. You pick up your pen. What is the very first sentence you write?
You have to start with precision. Definitions matter. Scoliosis is the lateral curvature of the spine greater than 10 degrees, combined with, and this is the key phrase, rotation of the vertebrae.
The rotation. That's the part people always forget.
And it's the most important part, really. The spinous processes rotate toward the concavity of the curve. And this rotation is what drives the ribs on the convex side, posteriorly, creating that rib hump you see clinically.
And kyphosis, just to be complete.
Kyphosis is simply an exaggerated posterior curvature of the thoracic spine, the classic hunchback. So kyphoscoliosis is that double whammy. You've got the lateral curve and the posterior curve.
Okay.
And right off the bat, for the examiner, you need to distinguish between structural and non-structural.
Structural being fixed, right? It's not going anywhere.
Correct. Structural means the bony changes are set. The curve doesn't disappear when the patient bends forward or lies down. Non-structural is more postural. It might correct with positioning or if you treat something like a leg length discrepancy. In the OR, we are almost exclusively dealing with structural scoliosis.
Got it. Okay, we've defined it. Now, why are we seeing this patient? Who are they, typically?
Well, epidemiology gives you your context. Idiopathic scoliosis is the big bucket. We're talking 70 to 80% of cases.
Okay.
And while the screening incidence is actually pretty similar between boys and girls, the progression to severe disease, the kind that requires surgery, is heavily skewed toward females.
So the classic exam vignette is a teenage girl.
It's almost always a teenage girl, likely in early adolescence, facing this massive physiological insult. But you do have to remember, while adolescents are the most common, you also see this in the elderly with degenerative changes, though the physiology there it's complicated by all the age-related comorbidities.
Right. Okay, let's move to section 2, classification. Examiners love a robust classification system. How are we breaking this down to maximize the marks?
Etiology is the gold standard way to classify. Think of it in 3 main buckets. Bucket 1, idiopathic.
Biggest one.
The biggest one. And you just break that down by age. Infantile is 0 to 3 years, juvenile is 4 to 10, and adolescent is greater than 10. Adolescent idiopathic scoliosis, AIS, that's the one you'll see most often.
Okay, simple enough. Bucket 2.
Bucket 2 is congenital. This is an embryological disaster. Something went wrong in utero. You have things like hemivertebrae, half-formed vertebrae, or fused ribs. And here is your first Viva gold star moment.
I am ready. Lay it on me.
If you mention congenital scoliosis, you must, almost as a reflex, mention the acronym VACTERL, or Vater Association.
Okay, let's unpack that. VACTERL.
So vertebral anomalies are the V. That's a given. But if the spine didn't form right, you have to look at the rest of the midline structures. A is for anal atresia, C for cardiac defects,
Oh, okay.
T for tracheoesophageal fistula, R for renal anomalies, and L for limb defects.
So if you see a congenital scoliosis patient coming to your clinic, you aren't just looking at their back. You're looking for a VSD, you're checking their kidney function, everything.
Precisely. The anesthesiologist who misses a coexisting cardiac defect because they were too focused on the spine, well, they fail the case. It's that simple.
And the third bucket.
Neuromuscular. And this is huge because the anesthetic management changes completely depending on the cause. We are talking about neuropathic causes like cerebral palsy, syringomyelia, or polio, and then myopathic causes like, and this is the big one, Duchenne's muscular dystrophy.
Duchenne's is the trap here, isn't it? I can feel it.
It's a lethal trap. I mean it. If you label a scoliosis patient as idiopathic when they actually have Duchenne's, and you give succinylcholine for intubation.
You get rhabdomyolysis, massive hyperkalemia, and cardiac arrest.
Exactly. So knowing the classification isn't just academic, it's a survival skill for your patient.
Wow. Okay. Before we leave the basics, we have to talk geometry. The Cobb angle. I can see the diagram in the textbook, but how do I describe it in words in a Viva without sounding like I'm failing high school geometry?
It's the Lippmann-Cobb method. Just keep it simple. You look at the X-ray, you identify the upper end vertebra, that's the one at the top of the curve that's most tilted. Then you find the lower end vertebra, the one at the bottom that's most tilted.
Okay.
You draw a line along the superior border of the top one and the inferior border of the bottom one. Then you draw lines perpendicular to those two lines, where those perpendiculars intersect. That angle is the Cobb angle.
And the numbers matter a lot. Give me the thresholds that I need to have memorized.
Absolutely. So greater than 10 degrees is the official diagnosis. 40 to 50 degrees is usually the trigger for surgery. But for us, the anesthetists, the danger zone starts at 60 to 65 degrees.
Why 60? What happens there?
That's the point where restrictive lung disease becomes clinically evident. I mean, lung function just starts dropping off a cliff. And if you see a Cobb angle greater than 100 degrees, you are in deep, deep trouble. That patient has symptomatic lung disease, dyspnea at rest, and a very high likelihood of cor pulmonale right heart failure.
Which is a perfect segue into the real meat of the exam answer, Part A, Section 3, Pathophysiology. This is where you explain why the patient is sick.
And the key word you must hammer home again and again is restrictive. This is extrinsic restrictive lung disease. It's not that the airways are blocked like in asthma. It's that the bellows, the chest wall itself, cannot expand.
Right, because of the cage deformity.
Exactly. The ribs on the convex side are pushed back, and the ribs on the concave side are all crowded forward. You just have a small, stiff chest cage. It can't move properly.
So what does that do to the lung volumes?
Everything goes down. Total lung capacity, or TLC, is down. Vital capacity, VC, is down. But the most critical one for us, for the anesthesiologist, is FRC, functional residual capacity.
Okay, let's dwell on FRC for a second. Why is that the killer? Why is that so important?
Well, FRC is your oxygen reserve tank. It's the air left in your lungs at the end of a normal breath that keeps your alveoli open. In these patients, the chest wall stiffness just collapses that reserve. Now, combine that with the fact that general anesthesia naturally reduces FRC by another 15 to 20%.
And suddenly your FRC is below your closing capacity. Your small airways just collapse.
Precisely. Small airways collapse.
Yeah.
Atelectasis sets in almost immediately upon induction. This leads to a huge VQ mismatch. You have blood flowing to parts of the lung that are squashed and have no air. That's a shunt. That's why these patients desaturate incredibly fast.
So hypoxemia is the earliest sign. What about carbon dioxide?
Yeah, this is a common misconception. CO2 retention hypercapnia is actually a late sign. Because CO2 diffuses so easily across the membrane, patients can usually hyperventilate enough to blow it off until the disease is really severe, until that Cobb angle is over 100 degrees.
So if you see it pre-op.
If your patient has high CO2 in the pre-op clinic, that is a massive red flag. That patient is not getting extubated on the table, period.
And eventually this lung problem spirals into a heart problem.
That lung-heart interaction is absolutely key for the systemic effects section of your answer. Chronic hypoxemia triggers hypoxic pulmonary vasoconstriction, or HPV. The pulmonary arteries constrict to try and shunt blood to better ventilated areas. But if the whole lung is struggling, the whole vascular bed constricts.
Which pushes up the pulmonary vascular resistance, the PVR.
Right, and the right ventricle has to pump against that high resistance. It hypertrophies, it dilates, and eventually it fails. That's cor pulmonale.
Okay, let's look at Section 4, systemic effects. We've covered the right heart. Is there anything else on the cardiac side we need to be looking for?
Mitral valve prolapse. MVP. It's spooky how common this is. Something like 25% of idiopathic scoliosis patients have MVP. You need to listen for that mid-systolic click. And of course, for congenital cases, remember VACTERL. You have to actively look for septal defects, or even something like tetralogy of Fallot.
And neurologically, what are the concerns there?
Well, the spinal cord itself is being stretched and twisted. So there is potential for spinal cord compression even before we touch them.
Yeah.
And you need to look at the skin, Do they have cafe au lait spots? That might suggest neurofibromatosis or von Recklinghausen's disease, which has its own whole set of airway and neurological implications.
Okay, we've built the physiological model. We understand the sniff box, the failing right heart, and the twisted spine. Now let's go to work. Part B, anesthetic management.
Right. Section 6, preoperative assessment. This is where you gather your intelligence. This is where you win or lose the battle.
History taking. What's the one question I absolutely have to ask?
Can you climb 2 flights of stairs without stopping? Exercise tolerance is the best functional test we have. If a teenage girl gets breathless walking across a room, her pulmonary reserve is non-existent. Also, ask about recurrent respiratory infections. It tells you her cough mechanism is weak and she's prone to post-op complications.
And investigations. We need hard data.
Pulmonary function tests. PFTs are mandatory. You are looking for that classic restrictive pattern.
And what does that look like specifically for the exam answer?
You'll see a decreased forced vital capacity, or FVC, and this is what distinguishes it from asthma normal, or even increased FEV1 FVC ratio. The flow is fine, the volume is the problem.
And an ABG.
You need a baseline arterial blood gas. If their PO2 is low, or if their PaSO2 is creeping up above 35 millimol HG, you need to have a very serious conversation with the surgeon and the parents about the high likelihood of postoperative ventilation.
And the heart, what's the workup there?
You start with an ECG, looking for right ventricular hypertrophy, tall R waves in V1.
Yeah.
But honestly, in a major case like this, you need an echo. You have to rule out that MVP, and you absolutely need an estimate of their pulmonary artery pressure. If they have pre-existing pulmonary hypertension, you cannot let them get acidotic or hypoxic intra-op, or you'll crash the right heart.
Right. Okay, let's move into the operating room. Sections 7 and 8, the plan.
The technique is general anesthesia. There's really no other option. You need a secure airway, you need muscle relaxation for the surgical manipulation, and you need absolute control of their ventilation.
I see students ask about epidurals sometimes. Can't we do this under regional anesthesia?
For the correction surgery itself, no, absolutely not. But placing an epidural for postoperative pain is a very valid strategy.
But it's hard to do.
It's technically a nightmare. The spine is rotated, the epidural space is distorted and hard to find. It's an adventure. But if you can get it in, it provides fantastic post-op analgesia.
Okay, airway management.
You have to anticipate difficulty. It's not just the spine. These patients often have short necks, limited mobility, and if it's a congenital syndrome, they might have micrognathia. Always, always have a video laryngoscope or a fiber optic scope ready. Do not burn your bridges with a standard Mac blade if it looks at all dodgy.
Okay, now here is a massive debate and a huge exam topic. Maintenance of anesthesia, gas or TIVA.
This is where the modern exam answer has really shifted. If the surgeons are using neuromonitoring, specifically SSP and MEP, you generally should prioritize TIVA, which is total intravenous anesthesia.
Let's drill down on why. Why is TIVA better?
It's all about the synapses in the spinal cord. Volatile anesthetics, sevoflurane, isoflurane, are potent suppressors of synaptic transmission. They dose-dependently wipe out the signals the neurophysiologist is trying to measure.
Especially the motor evoked potentials, the MEPs.
Exactly. MEPs are incredibly sensitive to gas. If you're running the SIVO at 1.0 MAC, the signals might just disappear. Then the surgeon screams, "I've paralyzed the patient," when actually you've just anesthetized the spinal cord. Propofol and remifentanil interfere much, much less.
So TIVA is the monitor-friendly cocktail. But what if I have to use gas? Maybe TIVA isn't an option?
Then you keep it low. The rule of thumb is to keep your volatile agent at less than 0.5 MAC. You'll need to supplement heavily with an opioid infusion. But really, TIVA is the superior answer for the exam.
Okay, let's talk about positioning section 9, the prone position. This is a topic examiners love because it kills people if you do it wrong.
It is a physiological stress test. Turning a patient prone, especially one with this pathology, initiates a whole cascade of problems.
Walk us through that cascade.
Okay, so imagine you flip the patient. If you let the abdomen squish down against the table, two terrible things happen. One, the abdominal contents push the diaphragm up into the chest.
Which just worsens the FRC that was already garbage to begin with.
Exactly. Your peak airway pressures go through the roof. But number two is the real killer, IVC compression.
The inferior vena cava.
Right. If you squash the IVC, blood from the legs and pelvis can't get back to the heart the normal way. It has to find a detour. And that detour is the vertebral venous plexus, also known as Batson's plexus.
And Batson's plexus is located
right inside the spinal canal where the surgeon is operating. And the thing is, Those veins are valveless. They become these engorged, high-pressure vessels. The surgeon just touches the bone and it bleeds torrentially.
So to be clear, abdominal compression directly equals massive surgical blood loss.
It is a direct linear relationship. The solution is using a Wilson frame or a Jackson table. These devices support the chest and the pelvis, but, and you must write this in your answer, they leave the abdomen hanging free.
Abdomen free is the magic phrase.
It's the whole game. It preserves venous return through the IDC, it keeps Batson's plexus empty, and it dramatically reduces bleeding. It also allows the diaphragm to move, which improves your ventilation.
What about the head, the eyes specifically?
The other nightmare scenario, post-operative visual loss, or POVL. This can be ischemic optic neuropathy or central retinal artery occlusion.
How do we prevent that? It sounds catastrophic.
You have to be absolutely religious about checking the eyes. There can be no direct pressure on the globe. You use a horseshoe headrest or a foam cutout, and you check every 20 minutes with a mirror. If the patient wakes up blind because you let the headrest slip onto their eye, that is a career-ending complication.
Wow. Okay, let's move to monitoring section 10. We touched on SSE and MEP. Let's clarify the difference for the listener because they can get confused.
Okay, think anatomy. SSE, or somatosensory evoked potentials, monitors the dorsal columns. That's the sensory pathway. You zap the tibial nerve at the ankle, and you measure the signal arriving at the brain.
But the problem is?
The problem is the blood supply. The dorsal columns are supplied by the posterior spinal arteries. But the motor tracts, the part that actually makes you walk, are in the anterior cord, supplied by the single anterior spinal artery.
So you could have a situation where the patient has a perfectly perfused dorsal column, so a normal SSEP, but an ischemic anterior cord, and they wake up paralyzed.
A false negative. A disaster. And that is why we need MEP, or motor evoked potentials. With MEPs, you zap the motor cortex of the brain and you measure the twitch in the legs. It monitors the corticospinal tracts, the anterior cord. It is much, much more sensitive to ischemia.
But there is a huge catch with MEPs and muscle relaxants.
A huge catch. You cannot paralyze the patient if you want to measure a muscle twitch.
That is a terrifying concept for a junior anesthetist. You have a patient prone, open spine, drills and hammers are working away, and you cannot use muscle relaxant.
That's the challenge. That's the art of it. You rely on deep TIVA with propofol and remifentanil to keep them perfectly still. If that patient coughs or moves during a crucial step, it's catastrophic.
Is the wake-up test still a thing, or is that just something we read about in history books?
It's the historical gold standard, and you must mention it in the exam to show you know your roots. If the electronic monitoring fails, or if the surgeon does a big correction and the signals suddenly vanish, you do a wake-up test.
Talk me through the mechanics of that.
You turn off the anesthetic, you wake the patient up just enough to follow commands. You ask them to squeeze your hand, then you ask them to wiggle their toes. If they wiggle their toes, the cord is intact. Then you bolus them with propofol and put them back down immediately.
The risks seem pretty obvious.
Oh, they're huge. Accidental extubation while prone, violent movement that could snap the rod or the spine, and psychological trauma from recall. It is very high stakes, but it works.
Section 11, blood loss. These surgeries are notoriously bloody. We're talking about decorticating large sections of bone.
It's raw cancellous bone. You can lose liters and liters of blood.
So what's our strategy to manage that?
It has to be a multimodal approach. Number one, cell saver. Intraoperative cell salvage is the standard of care. You recycle the patient's own red cells. Number two, tranexamic acid. It's an antifibrinolytic. You give a loading dose of 10-20 mg/kg and then run an infusion. It works.
What about controlled hypotension, the old technique of dropping the BP to reduce bleeding?
It's very controversial now. Historically, yes, we used to drop the mean arterial pressure, the MAP, down to 60. But now, we are terrified of causing spinal cord ischemia. Remember, that cord is being stretched and manipulated. If you drop the perfusion pressure too low, you might save some blood, but you could lose the spinal cord.
But what's the new target?
Most experts now advocate for keeping the MAP above 80, maybe even 90 millimilli-HG, especially during the distraction phase when they're straightening the spine.
Okay, the rods are in, the spine is straight, we're flipping them back supine. Section 12, postoperative management, the big question. Who gets the tube out?
Don't be a hero. You should plan for elective post-op ventilation. If, one, the Cobb angle was massive, say over 70 degrees. Two, the surgery took all day, more than 8-10 hours. Three, they had massive blood loss, more than 2 or 3 liters. Or four, if they had bad PFTs to start with.
And for pain?
Pain management is respiratory management in these patients. If they hurt, They won't take a deep breath. They won't cough. They get atelectasis pneumonia. A PCA patient controlled analgesia with opioids is standard. And if you got that epidural in, now's the time to use it.
Section 13 covers complications, but I want to quickly touch on venous air embolism. Why is that a specific risk here?
It's simple physics, really. In the prone position, the operative site, the spine, is often higher than the heart. The venous sinuses in the bone are non-collapsible. If they're open and the pressure is negative relative to the heart, air gets sucked in.
And the first sign is a sudden drop in end-tidal CO2.
Exactly. If that happens, you tell the surgeon to flood the field with saline, you aspirate your central line, and you support their hemodynamics.
Let's briefly distinguish pediatrics from adults in Section 14. What's the key difference?
For kids, you have to remember that alveolar multiplication continues until about age 8. So if they had scoliosis from a very early age, they'd literally have fewer alveoli. Their lung hypoplasia is structural and it's irreversible. Also, they lose heat much, much faster, so thermal regulation is absolutely critical.
And for adults?
For adults, it's all about the comorbidities. Coronary artery disease, COPD, diabetes. The spine surgery itself is hard, but it's the patient's other medical problems that usually cause the trouble.
Perfect. Let's wrap up with the Viva traps. Section 15, the fun part. What is the examiner waiting to catch me on?
Trap number 1, nitrous oxide. The examiner asks, "Doctor, would you use N2O in this case?" The answer is a hard, unequivocal NO.
And why not?
2 big reasons. 1, we just talked about venous air embolism. N2O expands air bubbles and can make a small embolus a fatal one. 2, N2O depresses SFE signals. Just leave it off. There's no benefit. Trap number 2, failing to explain why the abdomen hangs free. If you just say, to help with breathing, you'll get half marks. You must say to prevent IVC compression and therefore reduce bleeding from Batson's venous plexus.
Okay.
And trap number 3, forgetting the Duchenne's link. If the examiner gives you a vignette of a young boy with scoliosis, you must pause and think, could this be muscular dystrophy? Before you even think about reaching for the SSX.
And finally, diagrams. Section 16. If I'm writing that 20-mark answer, what am I drawing to impress the examiner?
You should definitely draw the flow volume loop. Draw the normal loop in, and then right next to it, draw the witch's hat.
The witch's hat.
It's the classic shape of a flow volume loop in severe restrictive disease. It's a tall, narrow loop. The volume on the x-axis is tiny, but the flow on the axis is preserved or even high. It looks like a tall, pointy hat. If you label it, it shows you understand the physiology instantly.
That's a great visual. I'll remember that.
Also, a quick sketch of the Cobb angle measurement on a spine schematic is easy marks, and a simple flowchart of the prone, positioning, safety, steps, eyes, neck, abdomen, knees is very effective.
Fantastic. Let's summarize this whole thing. We've covered a massive amount of ground. Section 17, bring it all home for us.
Okay, to recap for your exam answer. 1, definitions. Scoliosis equals rotation plus a lateral curve. 2, physiology. It's a stiff box. That means low FRC, restrictive lung disease, and a big risk of cor pulmonale. 3, pre-op. You must check the Cobb angle, the PFTs for that restrictive pattern, and an echo for MVP and pulmonary hypertension. 4, intra-op. General anesthesia with TIVA is best, especially for MEPs, and safe prone positioning, which means abdomen free to save Batson's plexus. 5, monitoring. NEPs for the motor tracks are crucial. Keep the MAP above 80 mmHg to perfuse the cord. 6, post-op. Don't rush to extubate if the pre-op state was bad or the surgery was long and bloody.
The surgeon's goal is a straight spine. What is our goal as anesthetists?
Our goal is a patient who wakes up, moves their feet, and can breathe. We are the guardians of the spinal cord and the lungs. The surgeon straightens the bone. We keep the patient alive and neurologically intact through that massive insult.
There you have it, a masterclass in kyphoscoliosis anesthesia. Visualize that flow volume loop, remember Batson's plexus, and you will absolutely crush that exam question.
You've got this. Good luck.
See you next time on The Deep Dive.